So in this presentation, I'm going to be talking about Candida auris, and I will also discuss a couple of challenging cases that we faced. And now, this is the list with the WHO published of the fungal priority pathogens to guide research, development, and public health action. And you know, there are three groups, the critical, the high, and the medium group. And you can see in this list that Candida auris has made the critical group. So that means it's really a pathogen which is of high priority. And so the question that we need to ask is that why is Candida auris in the critical group? The first is that it is difficult to identify by conventional methods, and it is often, misidentified as other Candida like Candida fumata, etc., to identify it. And therefore, if your lab is not well equipped, you may miss it. The second is that susceptibility breakpoints have not been well defined, and that is a problem. Third, it is multi-drug resistant and difficult to treat. Almost all the isolates are fluconazole resistant. 50% are amphotericin B resistant, and often the only drugs that we have are the echinocandins. Mortality rates associated with Candida auris are about 30 to 60%, and that is a big problem. And finally, one of the most challenging things about Candida auris is that it causes nosocomial outbreaks. In fact, the fungus can colonize the skin for prolonged periods, leading to contamination of healthcare worker hands and environment to person in the ICU. It is thermotolerant, osmotolerant. It can survive for weeks in the environment. It is resistant to inactivation by common disinfectants and antiseptics. It is in fact a superbug. So once Candida auris enters your ICU, whether it is the neonatal intensive care unit or the pediatric intensive care unit, it is difficult to get rid of it. And you need to really up your infection control measures. And that is why many ICUs actually get colonized by Candida auris. And once a person gets colonized by Candida auris, one can assume that that person can remain colonized for years together. So therefore, in a nutshell, it is challenging to diagnose, challenging to treat, and challenging to prevent. Now, Candida auris has become a major cause of candidemia in adults in India. And this is, in a nutshell, many studies which have it contributed to only 5% of all cases of candidemia.
Tanu, sorry to interrupt you, but maybe if you switch off your camera, because sometimes you're interrupted with your sound. Thank you. Okay, is it better now? So yes. As you can see that over the time, the episodes of the contribution of Candida auris towards the episodes of candidemia have increased to almost 40% now. There have been many studies which have been conducted recently which show that Candida auris is contributing to almost 40% of all cases of candidemia in adults. And that is particularly challenging. So much so that now the empirical therapy for all cases of suspected candidemia in adults has become echinocandins. Is it better now? Is the voice better?
Yes.
Okay, thank you. Now, moving from adult to the neonates, before we move on to Candida auris and neonatal candidiasis, it is essential to understand the epidemiology of neonatal candidiasis in India. We all know that in the high-income setting, neonatal candidiasis is seen in extremely low birth weight babies, and where the usual causative pathogens are either Candida albicans or Candida parapsilosis. There is a high rate of dissemination to the CNS. And units where the rate of candidiasis is more than 10% practice prophylaxis with fluconazole with very good results. But in India, the epidemiology of neonatal candidiasis is different. This is a very important study which was done between 2011 to 2015 in New Delhi, where they enrolled babies outborn babies with sepsis. And they found that out of 401 culture positive sepsis cases, Candida was the single most important cause, even more than bacteria. And they also pointed out that the babies who had Candida sepsis had a mean birth weight of 1800 grams and their mean gestational age was 34 weeks. Two-thirds of these babies were born after 32 weeks and had a birth weight of more than 1500 grams, and 90% were diagnosed within 12 hours after admission into the ICU. In fact, what was more important was that 25% were not hospitalized previously, 40% had not received any antibiotics before they came to hospital, and 16% had not been ventilated. And here, the more common, the pathogens were albicans, tropicalis, cruzi, and parapsilosis, and Candida auris was not described because this was an early study. So therefore, this study pointed out that the epidemiology of neonatal candidiasis was outside the usual risk group, which was seen in high-income settings. But this is an important study to discuss in today's presentation because this was our chairperson is actually one of the authors of this study, and this is the NEO-OB study, which was a longitudinal observational study in infants less than 60 days in 19 sites in 11 countries, which included babies who had clinical sepsis and babies who also had Candida isolated in blood culture. And this was conducted in low and middle income countries, but 14 hospitals in 8 lower middle income countries, but 85% of these isolates came from 3 countries, India, South Africa, and Vietnam. Of these 127 isolates, 40 isolates were from India. So the data which I'm going to present is not just confined to India, but it is representative of what is happening in India as far as neonatal candidiasis is concerned. So again, this more or less reflects the same thing, that the babies who develop neonatal candidiasis here in low middle income countries are babies who are older, who have a higher birth weight, and also that they are here again, you can see that these babies are more than 28 or 32 weeks. They are more than 1500 grams. And in fact, what was important to see in this study, that while Candida albicans and Candida parapsilosis were the major causes, 14% of the isolates were C. auris. And the only C. auris isolates were either from India or from South Africa. And in India, the prevalence of C. auris as a cause of neonatal candidiasis was 27.5%. And of the C. auris isolates, for overall, the prevalence of fluconazole resistance was 40%. The prevalence of ampho-B resistance was 18%, and none of the isolates were micafungin resistant. Whereas in C. auris, the fluconazole resistance rates were very high. Another important point which this study brought forward was that the rates of antifungal prophylaxis, even when they were recommended, was not there. So again, here, this study showed that C. auris was an important cause of candidiasis in the Indian cohort, and the mortality rate was quite high. Another important point which I would like to show in this figure, because this data is from India, that you can see that most of the Indian babies got amphotericin B, some got fluconazole, and voriconazole was given in 10 babies. Now, this is obviously improper use of antifungals because voriconazole is not recommended as any antifungal in newborn candidiasis. So this study showed that Candida auris is on the rise in newborn candidiasis in India and even in South Africa. This is another study from South India which showed Candida auris in 5 babies who were less than 800 grams, and 80% of these babies died. Another study from South India described 17 neonates with C. auris, and here again, they found that these were older babies, many of whom had prior gastrointestinal or cardiac surgery, and many of them had coexisting gram-negative sepsis. They had other risk factors for candidiasis. This study also gave one important information which none of the other studies gave, that only one of these 70 neonates had CNS involvement. this is perhaps an important information that we need, because we know that with Candida albicans, you have a high rate of CNS involvement, but it seems that with C. auris neonatal candidiasis, the rate of CNS involvement seems to be low. Maybe it does not have that much neurotropism that C. albicans has. Another important point which the study brought out was that the rate of mortality was higher in those babies that were treated with amphotericin B, but it was low in those babies who received micafungin. However, the study did not mention the degree of, they just did not give the susceptibility results properly. So it is probably possible that the babies who received amphotericin B may have been resistant to it. And there was another point in this study because they had a very high rate of Candida auris in their ICU. The unit started a policy of using micafungin prophylaxis for some time, where they gave 3 mg per kg of micafungin following this outbreak, and they didn't have any C. auris infections. But I'm sure that this is not something which we would like to do on a regular basis. And then this is data from our own center, where we also reported that of all the case of 19 cases of pediatric candidemia that we had, of which 9 were neonates, the most important cause of candidemia was Candida auris. And in the newborns, 6 out of 9 cases were due to C. auris, and we did not see any case of meningitis. And another important point was that the rate of amphotericin resistance was as high as 71%. So with this, I just want to share this case. This was a 8-day-old term IUGR neonate who had a TOF, pulmonary atresia, and a duct-dependent circulation. He also had a stenting of a duct done on day 8 of life with a prolonged ICU stay. After this, he developed a necrotizing enterocolitis and developed a bloodstream Klebsiella infection, because of which he needed surgery and he needed broad spectrum antibiotics and TPN. So in short, he had a lot of risk factors for a fungal sepsis. But despite this, he did not receive antifungal prophylaxis because he really didn't fit into that group which would receive fluconazole prophylaxis. After which he developed recurrent hypoglycemia, thrombocytopenia. Paired blood cultures were sent, which grew C. auris. His central line was removed, the tip grew C. auris. And as you can see, the sensitivity, he had isolate, which was resistant to amphotericin B, sensitive to the echinocandins. But apart from having candidemia, he also had a vegetation at the junction of the superior vena cava with the right atrium. So he had candidemia with endocarditis. So the only option we had was to treat him with micafungin. Estimate guidelines say that we should have added flucytosine, but because the baby had NEC, we couldn't give flucytosine, though we treated him with micafungin. Now, while even anidulafungin is approved for newborns, but the data is maximum with micafungin, so we gave micafungin at a rate of 10 mg per kg per day, with which we were able to demonstrate sterilization of blood cultures, and we treated him for 6 weeks, and we were able to successfully cure this baby. So Candida auris was responsible for prolonging this baby's hospital stay by 6 weeks. So the key points regarding neonatal candidiasis in India and Candida auris is that first, neonatal candidiasis, there's a significant burden, occurs outside the traditional risk group, and the contributing factors are maybe poor infection control and overuse of antibiotics, and therefore prophylaxis with fluconazole, which is anyway underutilized, may not be very effective. As far as C. auris is concerned, is emerging, and CNS involvement appears to be less common as compared to C. albicans. Amphotericin B resistant rates are significant, which leaves us with echinocandins as the only option for treatment. And if we compare the cost of therapy with echinocandins, then 2 weeks of therapy for a 2.5 kg baby would cost $1,000 compared to only $50 for amphotericin B deoxycholate. So that is a problem in a resource-limited setting like ours. And it also imposes burden on infection control resources. And if C. auris becomes the major pathogen in the neonatal intensive care unit, then again, fluconazole prophylaxis will not be appropriate, and you will have to look at other options. Now, if you move from neonate to pediatric setting, in 2011 to 12, the rate of C. auris in pediatric setting was 2.2%. And we really don't have any data about what is the prevalence of C. auris in the pediatric critical care units. But it should be high, given the fact that in adult critical care units, it is in the rate of 30 to 40%. So with this, I just want to share this last case of which we had recently in our ICU of a 5-year-old girl from Madagascar who had a pilocytic astrocytoma with bilateral VP shunts to manage her hydrocephalus, who was transferred to our hospital for further management. And she underwent near complete tumor excision and had to undergo chemotherapy for the residual tumor. She had developed febrile neutropenia and she was transferred to our ICU and given empiric antibiotics. But when her sensorium dropped, we had to do an MRI which showed an increase in hydrocephalus. And as you can see from these images, she had a this was a pre-op MRI and this is the tumor. And post-op, we saw that there was an increase in hydrocephalus, and this is the post-op cavity of the tumor excision. So the VP shunt was removed and an EVD was inserted. And you can see we sent serial EVD CSF. And you can see initially the CSF was not remarkable. But on day 7, when she developed fever, we found that the cells had increased in the CSF. And there was increase in the drop in sugar, increase in the lactate. And the CSF was positive for C. auris. And here, this time the amphotericin MIC was 1, but it was resistant to flucytosine and sensitive to the echinocandins. The identification was done by Malditov, but the susceptibility was by Vitek. So again, we now have a case of CSF, Candida auris EVD-related CNS infection. Now, as per the guidelines, we started liposomal amphotericin B at 5 milligrams per kg per day. And ideally, we should add flucytosine, but it was resistant, so we could not use it. We had to keep the EVD because she had hydrocephalus. So we decided to use the EVD to give intraventricular caspofungin. We could have used amphotericin B deoxycholate, but we had experience with using caspofungin in a previous patient with C. auris ventricular infection, with which we were able to sterilize her CSF. And with that, we removed the EVD and inserted a VP shunt when the CSF became sterile, but we continued the liposomal ampho-B for 6 weeks. So this was a paper which we published previously of a patient who had a C. auris shunt infection, where we gave intraventricular caspofungin, because in this patient, the isolate was resistant to amphotericin B. So we only could use intraventricular caspofungin and oral voriconazole for treatment, because the voriconazole MIC was 1 and it was just that, we could just use that therapy. We couldn't even use liposomal ampho-B. So with that, I would like to conclude by saying that Candida auris is an emerging nosocomial pathogen in India. It is challenging to diagnose, treat, and prevent. Awareness about this pathogen in India is increasing because of efforts by our Indian Council of Medical Research, also by a fungal infection study forum, of which I'm a member, and also because of microbiology societies. Generic brands of echinocandins are now available in India, which have reduced cost of therapy. So it is possible for some patients to access them and reduced cost. But this is also leading to overuse of echinocandins. And there are cases of sporadic cases of resistance to echinocandins in C. auris. And another major problem that we face is to implement infection control precautions for C. auris, because once, like if you look at the guidelines, if a patient has C. auris in your ICU, you're supposed to implement strict infection control, put barrier precautions, and cordon off that area of the ICU, screen all the contacts, etc., which we are not able to do. So indeed, it's really a very, very challenging pathogen. Thank you so much.
So I will talk today about Fusarium species in Brazil. And what I prepare to show you is I want to discuss 4 points here. The first one is I will introduce you Fusarium, our villain. So we will talk about the agent. Then I will explain or talk something about the geographic distribution, and then we will talk about the incidence. And then how we acquire this disease and how is the behavior of this disease in our in the organisms. And then we will talk about pathogenesis. And finally, we will talk about treatment and what are the challenges of management and what the management of this disease impacts on the outcome. So there are 4 points to discuss today. And the first of all, I will introduce the villain, that is Fusarium. Fusarium is a mold saprophyte fungi. It is a phytopathogen, so it is spread in the nature and especially in plants. We can see Fusarium on core, on banana, on pineapples, and it's in the nature and ubiquitous in the environment. And here we see some photos of the corn with Fusarium. We can see the growth in the plaque and the microscopy. And this fungi, it can cause rapidly invasive disseminated infections, depends on the severity of immune status of the patients. So Fusarium can cause a localized infection in immunocompetent patient, or it causes a severe disease, especially in patients with active hematologic cancer, patients submitted to hematopoietic stem cell transplantation, and it causes a disseminated disease. So the characteristics of the disease depends on the immune status of the patients. Here we have some picture of disseminated disease that is very, very severe in this kind of patients. And where we can have this disease. So it's not a common fungal infection, it's a rare fungal infection, but is especially more frequent in some areas of the globe. So here is a review from a Brazilian author that he picked up all the studies about Fusarium in the literature, and what he saw is we have incidence in Europe that is about 37%. We have in United States about 60%, and only one country in Latin America, that is Brazil, we have 19%. And when we saw the incidence, we see outside Brazil, the incidence rate is from 0.1 to 1.7. And when we see only in Brazil, 1.6 overall, and with a high incidence in patients immunosuppressed as acute myeloid leukemia, that it can achieve 3.8, or even in stem cell transplantation, hematopoietic stem cell transplantation, that can achieve 5.2 the incidence. So it is more frequent in Latin America. We have more publications here, and especially in Brazil. And this is all these publications are in pediatric and adult patients. And last year, we did a review only for the publications in children. And we saw that in children, we can see here in these slides, Brazil is more red, that it shows us in Brazil, there are more than 20 cases of fusariosis in children. So it is more frequent here. And how is the behavior of this disease? Então, it's not so frequent. It is more frequent in Latin America, in countries with temperate climate. So how is the behavior of this disease. And to explain the behavior of this disease, it's important to know how the patients can acquire the disease. And we have 4 routes, major routes of acquirement of this disease. The first one is the skin breakdown, and the skin breakdown we can see here, we can acquire from the central line, the venous central line, and we have here in my hospital an outbreak that was related to the central venous line, the catheter, and it was related with the place where the catheter were kept. So it's important because it can be a root of the disease. The other roots that is related to skin breakdown is the onychomycosis or interdigital intertrigo that the fungi can achieve the blood by this way. So this is a publication from a group in Brazil, and they show that 11% of the patients can acquire fusariosis by this route. The other route is the inhalation of propagals of fungi, and we can inhale this fungi for many ways. Here we have a structure of a nursery ward that was with a lot of mold, and then the patient can inhale this mold and develop the disease. The other way is some construction behind the hospital or near the hospital, near the room of the patient, and they can inhale this. And the other source of infection is the water, that we have the aerosolation of the propagals, and then the patients can inhale these propagals when they were taking bath. So the disease can be can come from sinus and lungs, and the behavior of the disease depends on the immune states, can be very severe. And then how is this behavior in children, and what are the risk factors to acquire this infection in children? And this is a publication from our group that we look in the literature, all the papers about Fusarium in children, and we found 106 cases published, and the majority of these are case reports or small series, and we see here that the majority of the patients who developed fusariosis had as underlying condition hematologic malignancy, 64%, and neutropenia was the main factor to this disease. So it just confirmed the importance of the immune status for this disease. And we try to see what happens in the small kids comparing with the older ones. And we saw that patients who are under than 3 years old, they are more likely to develop severe infections. And what claim our attention as these patients, they have more other hematologic condition comparing with patients older than them. And why is so important? So the immune status is very important to Fusarium to infection to Fusarium. So innate immunity plays a major role on control of this infection. So the agents need we need the neutrophil to do the EFL damage and control the infections. And patients who are in immunosuppressed condition, like patients who are receiving corticosteroids or have GVHD or stem cell transplantation that can impair the function of T cell, or patients who are neutropenic, they are more likely to have this kind of infection. So the neutrophils and the T cell are very important on the control of this infection. And how this infection, what are the clinical syndromes that we can see when we are facing this disease? So the airways are the main entry point. So the foremost clinical presentation are patients can present with fever and metastatic lesions that are skin lesions that are very characteristic of this disease. We can also have pneumonia. Patient can have only fever with a positive blood culture. Fusarium grows in the blood is frequent, common. And the fourth presentation is cellulites or lymphangites at sites of skin barrier disruption. So this is the four presentation that are more common, but we also can see less frequent arthritis and sinusitis and fungemia related to central venous catheter. So here I show to you some kind of patterns of the skin lesions. So we can see here a target lesion. Here we see centrum with is more dark, sometimes with necrosis, and this halo of erythematous halo. Here we can see a ulcer, and this is the patient with a lot of lesions, and it progresses very quickly. Like on the first day, we have only this one, and this is in the third day. So it's very fast. And we also can see here, we see the target lesions as we saw before, but we also can have vesicles or necrosis or even ulcer, a deep ulcer. So it's very variable, the pattern of the lesions, and it can start like this, only erythematous nodules, maculas, and the vesicles like this. So we need more than pattern lesions. So I always say that we have to look for the patient as a whole, like a total. We need to look to entire patient. So who is this patient? What kind of immunosuppressant that they are they were underwent for, if there are a patient who are receiving immunosuppressant as corticosteroids and they are neutropenic. And then when you face a lesion like this, we need to do the biopsy. And if we are in Brazil, in my hospital, we also think about Fusarium. And Fusarium also can cause sinusitis. This is a kid, female, who has ALL relapsed and are with a neutropenia for many, many days. We can see here like 2 months of neutropenia, and she starts with blood in the nose, and we do the MRA, and we saw here disruption of the bones, and we did a biopsy and grows Fusarium solani. We also see Fusarium on CNS, and here it's from literature that we can see an abscess on the brain. And we are in this kind of patients, Fusarium, the disseminated presentation is not uncommon. So if you have a blood culture with Fusarium and we have skin lesions, and it's important to seek for other sites. And here is a recent publication from 2022, and they evaluated 22 cases of Fusarium. And it's interesting that he point out that solid tumors who require intensive immunosuppressive therapy were reported in 12 of pediatric patients that develop invasive fusariosis. So it's not only the kind of tumor, but the kind of immunosuppressor that these children are submitted for. The other thing is the capacity of Fusarium invade deep deep sites in children. In this publication, bone and joint was involvement in 8% and eye and central nervous system in 8%. And then we performed research in Latin America. It was 10 hospitals that was enrolled in this research. We saw 60 patients. It's the bigger series of Fusarium published in children, and we compared with adults, and what we saw is the majority of the patients has fever, skin lesions, and pulmonary lesions. And we saw also, as the other paper, some patients who develop deep-seated infections, especially osteomyelitis and endocarditis and central nervous system. So we have to look for this kind of presentation in children. And how do you do the diagnosis? Skin lesions are present in 7% of the cases. This is a case from my hospital, and the development in 3 days, he started like this, and he is very immunosuppressed patients with ALL relapsed. He underwent to hematopoietic stem cell transplantation. He had CMV previous and a lot of viral infections, and he was neutropenic for 4 months. Did a skin biopsy that was
Você não tem
positive.
nenhum contato chamado SM.
We did the skin biopsy that was positive. We did the blood culture and galactomannan. And what I want to show you is that galactomannan can be used to do the diagnosis before the clinical presentation. So this is from this patient. We were collecting surveillance of galactomannan, and then the galactomannan was positive before the skin lesions. And in our paper, we saw a positivity around 11.7% of our patients. And to finalize the challenge on treatment, we have the global guideline for treatment of rare molds. And what they recommend is monotherapy with voriconazole or with a lipid preparation of amphotericin B, but they put here with or without combination with. So if you start with voriconazole, it can be combined with amphotericin, and if you start with amphotericin, it can be combined with voriconazole. It was they recommend in my hospital. We start with combined therapy. And to finalize, I just want to mention this article that is recent, published in 2024. It's not for children, but it is a huge series about fusariosis in patients with leukemia. 114 patients infections confirmed, and the majority occurred in patients with leukemia that was relapses or refractory. 90% were neutropenic, and 64% develop breakthrough fusariosis during azole prophylaxis, and 84% received combined antifungal therapy. And just to show that this disease occur in immunosuppressed patients, even if they are receiving prophylaxis. And if you are in the endemic area, you have to think about Fusarium. And the galactomannan was positive in only 24%. So the thing that was more important to better outcome is the neutrophil recovered. So in conclusions, we discuss our 4 points. So the first one, Fusarium are ubiquosaprophytic modes that cause disease in plants, and a wide spectrum of infection in humans, ranging from chronic superficial to rapidly invasive disseminated infections in vulnerable hosts. So this is our agent. The incidence is more frequent in Latin America, and it's especially related to the temperate climate. So the incidence. The clinical form of fusariosis depends on the host immune status and the portal of entry. Deep seat infections are more prevalent in children, almost 20%. The diagnosis, it's a combination of clinical symptoms. We need to keep in mind the skin lesions, culture, especially blood culture or culture of the lesion, and histopathology with molecular techniques. And the success of treatment involves antifungal therapy, recovery of immunity, and surgery. And the primary therapy, either voriconazole or a lipid formulation of amphotericin B, it is what it was recommended by the guidelines. And the combination therapy, particularly with voriconazole and amphotericin B, is also an option and may offer the potential of early transition to monotherapy. So this is what I have to talk with you today.
Hi everyone, thank you. I had a question for the Fusarium actually. I was wondering if the patient is already on posaconazole prophylaxis, would we still expect a Fusarium infection, a breakthrough infection? And if the answer is yes, would we still consider the first line treatment as the voriconazole, or would we, I only had one Fusarium patient and we gave the combination treatment, and I remember the patient was already on azole prophylaxis, but we don't have the TDM. I don't know if he already had the effective therapeutic drug levels. I was wondering,
Okay, thank you for the question. We don't have many literature about other azoles than voriconazole to treat of Fusarium, and either posaconazole or isavuconazole, we don't have many data of it. There are other things that you have to keep in mind when you are using an azole, and it is a breakthrough infection like TDM. In my country, I don't have a posaconazole tablet or IV formulation, so I use a suspension. So we don't can make sure that we have good serum levels of this, but it's not a good choice for treatment of Fusarium. I think if you have a breakthrough with posaconazole, we can move on to amphotericin, and you can use voriconazole too. And I like the combination of both. I don't know, Andreas, that if you can say anything about posaconazole and Fusarium, but
Thanks a
I
lot.
never use. Yeah.
Thank
Yeah,
you.
I think the important things here are to ascertain whether the patient was on a effective dosage of posaconazole, had an adequate exposure, or was compliant, so whether this is a true breakthrough infection. And then, of course, I would try to get in vitro resistance data on the isolate and see whether, I mean, sometimes there may be breakthrough infections despite activity of the prophylactic drug against this organism. Secondly, there may be differences in susceptibility between posaconazole and voriconazole because they are structurally different. So you have to check adequate exposure and compliance in the patient and get the results of in vitro susceptibility testing of the organism, and then make a decision based on this information.
Thanks a lot. Thank you.
Thanks, Andrea. Any other questions from you? Fabian, I had a question for you, and then another one for Tanu. So when you were mentioning an outbreak of Fusarium related to catheters, and that then you found out it was related to where the lines were stored. Can you tell us through that process to find out? We have had recently a case with a mold. In this case was Aspergillus, but it was also line related. And I'm very interested in that process of how it could happen.
Thank you, Laura, for the question. It was a very hard time in my hospital, and we couldn't prove that the source was the storage. We assumed it because we couldn't find the source. But we started to have many cases, like we had 7 cases of fusariosis, and all the cases are patients that they are under than 7 years old, and they receive chemotherapy in our unit. And the chemotherapy in our chemotherapy unit, we have one side for older children, and the other side for young children. And all young children have had fusariosis. So we started to look for the air in the chemotherapy, and we look air conditioner maintenance, the lab results of the air, the first one. Then we look in the water. We look all the medications that they receive, and there are some chemotherapy that are common. They receive vincristine, and then we analyze the vincristine that it can be the vincristine, and we also look in the nails of the nurses that are manipulating the catheter, and then other case, and then other case. And then we look where the catheter was storage, and the humidity was like 70%, and the law allowed 60%. So it is in the place that were made of wood, and there are a lot of humidity there. And then we pick all the catheters that were storage there, and we roll out. We not used it anymore, and the outbreak was controlled. So we don't know if it is, but it was what we did in that time. And we published this series, and all the patients, they have good neutrophils, and we look for Fusarium in other sites, but we couldn't find in other sites. So we look air, water, environment, and medications, and nurses, the nails, and the storage of the catheter.
Thank you so much. Very, very challenging. I see, thank you. I see that Emmanuel has his hand up. Emmanuel.
Yeah, excellent. Both talks were actually excellent. That I enjoyed them very well. I have a question for Tanu. Do you there are reports of Candida auris in neonates, and actually those were the early reports. Do you think these are cases spill over from adults? I mean, is that they? How did they go to the neonates? Are they, endogenous or from the personnel, from hospitals which have both adults and the neonates? I think this is something that I would like to know in your case. And second thing that I wanted to ask, did you see, because you have a quite high percentage of resistance to amphotericin B, which is actually very worrisome. So you have only echinocandins to treat them. Now, have you seen any cases of Candida auris resistant to echinocandins as well, like pan-resistant cases? Because we have seen, well, not us, but described in the literature, echinocandin resistance may be developed during the treatment with echinocandins. So, two questions.
Yes, to answer your first question, I think Candida auris must be coming from the hands of the healthcare workers and on the environment, because I'm sure it's so hardy. It must be coming from the environment and the medical equipment, because it can stay there for weeks. So it must be there in the hospitals, in the units, etc. Because there are very few hospitals which are like standalone neonatal hospitals. They are multi-specialty hospitals. So I guess it will be there, the health. So they must be carrying it and bringing it in the NICUs. Because when they have done studies, they have cultured Candida auris from equipment as well. And it has been there for weeks, and it is so thermotolerant and osmotolerant that it can be there. It is resistant to desiccation as well. So it can survive for a long time. So I guess that is how it is probably there. The second thing is that we have seen cases of Candida auris which are resistant to one echinocandin but not the other. So differential susceptibility is sometimes seen. So we have seen cases who are on treatment with caspofungin who become resistant to that but are still sensitive to anidula fungin. But pan resistance we have not seen yet. But there are reports from other hospitals in the country which have started seeing resistance to the echinocandins because of mutation in the FKS1 gene. So that is there. So some isolates of pan resistance are there, sporadic cases. So that is the worry, actually. That is the worry.
Thank you.
Thank you, Tanu. And Andreas, do you have any comments about Fusarium or Candida auris that you would like to present?
Yeah, I was just thinking about, and we talked about this recently, the galactomannan and the role of the galactomannan as a diagnostic tool or as a tool for monitoring treatment responses. And I was just doing a little PubMed search while I was listening to the discussion, and As far as I can see, all the assays that are available, the Platelia enzyme immunoassay and the ELISA, there is cross-reactivity reported between or for Aspergillus species and also for Fusarium, although the detailed galactomanans in the two fungi seems to be different, but there is cross-reactivity. So in confirmed cases, the galactomannan may also be a tool to to monitor treatment responses if the galactomannan was positive at some point. But altogether, what we have seen from the extent of the galactomannan expression, it seems to be rather on the low side. And maybe Fabianne, what is your experience with the galactomannan altogether, or what is your assessment for clinical purposes?
We do galactomannan here in my hospital as surveillance in high-risk patients, and what I saw is I have many Fusarium cases that have galactomannan negative, and I have some with galactomannan positive. So I can't trust in galactomannan to do the diagnosis because not always it can be positive. So if it is positive, it helps. But if it is negative, I think it can't rule out Fusarium infection. So it's not so reliable to do the diagnosis for Fusarium, I think.
Yeah.
What I can, our patients, if they are risk patients and they develop any kind of skin lesion, we must to do the biopsy, because I think it's the main route to do the diagnosis.
Yeah, I think this is an important point, and it's interesting because as most Fusarium infections are systemic diseases with fungemia and dissemination via the bloodstream, and despite this fact, the galactomannan is negative in many cases. So despite the presence, obviously, of hyphae, it does not react. So there seems to be differences. Yeah.
Yeah.
How about immunotherapy, Fabianne? Do you use cytokines or neutrophil transfusions or things like this, in addition to that?
When we have a Fusarium, a case of Fusarium, and patients is very immunosuppressed and neutropenic, we performed a granulocytes transfusion in my hospital, and I saw. I thought that it does difference. We improve the immune status of this patient, and I think the outcome is better. It is not easy to do the granulocytes transfusion. We need to have donors, we have to stimulate with corticosteroids, and it's not easy. I saw some adverse events, like I had one patient that was, I think, 17 or 18 years old, and start with the lesions, and on the third day he was a cover of lesions, and then we started the granulocytes transfusion, and the patient had severe respiratory failure. Everything grows to the lungs, and he almost died. And after this, he recovered, and then we perform again the granulocytes transfusion, and then he it goes well. But on the beginning, I have some adverse events in 2 patients with granulocytes transfusion. But we do this, and we believe that it is a good adjuvant treatment for this severe disease. And we do this for patients who had Fusarium, infection of Fusarium, and recovered, and then needed to go to the hematopoietic stem cell transplantation. And then we do granulocytes transfusion as a prophylaxis to have other, like secondary prophylaxis with antifungal therapy, a systemic antifungal therapy.
Thank you, Fabianne. So also because we are reaching when we are going to finalize, but so we have two comments. So first one, Adilia, and then Andreas, please.
Yeah, thanks, Laura, and apologies because my internet dropped out for a while. So I'm not sure if you have discussed on this topic already, but I was quite keen to hear from Tanu how she is thinking about antifungal prophylaxis in neonates or in other at-risk children for candidemia with such a high percentage of Candida auris, and with fluconazole prophylaxis, which is kind of one of the first choice for anti-Candida prophylaxis. I'm just thinking, how should we kind of approach that, or should we not give antifungal prophylaxis in those situations? Because if you would give an antifungal prophylaxis with echinocandin, you would also lose your first line of treatment. And I am just struggling myself, what would be a way to deal with that. So I would be very keen to hear from Tanu how you are approaching that, Tanu, in your situation.
So there are 2 issues. One is that Candida is happening outside the risk groups. So we would have to think of who to prophylax. Because if we just prophylax people below 1,000 grams or 1,500 grams, most of the cases of candidemia are happening outside. So the target population will have to be defined. That is the first question. And the second is with what to prophylax. Because if we use fluconazole and the prevalence of Candida auris is high, then fluconazole would not work. So I had looked at papers which looked at, one was nystatin, because the nystatin susceptibility of Candida auris is about more than 50%. So maybe we could look at that option. Also there is some data on probiotics as prophylaxis for candidemia. So maybe we would have to look at other strategies for prophylaxis. I don't know, what are your thoughts on this? Because should we look at other options for prophylaxis?
Yeah.
And we have to widen the net for prophylaxis, because all the cases of candidemia are occurring outside that net of 1,500. And when we look at the our data, like the cases which happened in our hospital, they were all babies who had undergone surgery, either cardiac or GI surgery. Those were the ones who got it. And when we looked at that study, 17 neonate study, those were also babies who had undergone surgery. And maybe it would be interesting to look in neo-obs if we can get individual patient level data. Who were those babies who got Candida? Then we would be able to define that group, and then also think of these other strategies for prophylaxis.
Or prevention as well, not just
prevention as well. And
is
also
key.
important to note that, none of the patients who really even merited prophylaxis were getting it. You showed in your study that only 9% of the babies below 1,000 grams actually got prophylaxis.
Yeah.
So there is poor awareness as well about prophylaxis.
Thank you, Tanu. I think that all the prevention around a case is always important in the
Infection
context
control,
of
I
outbreaks
guess.
with papillomavirus.
Infection control, I guess.
Infection control, I think because no matter, I feel how much we would give prophylaxis, if we wouldn't ramp up infection control, it would probably not work. That's my thought.
I would agree. And Andreas, one last comment or question? You have to unmute.
Sorry. Yeah, this is a comment on infection control. Tanu concluded that the whole bundle of precautions is not possible to be implemented in the setting that she was referring to, and I think this is a very sobering information. I mean, in many ways, Candida auris appears to be biologically similar to methicillin-resistant Staph aureus in the biological behavior and the ways of transmission in the hospital. And if we are unable to implement appropriate infection control measures, we have to acknowledge that this organism will distribute within the hospital, that it will distribute further in the community, and that we essentially have to deal with it when it infects people, and then we have to deal with the resistance issue. So I think we should focus on infection control, and that's very important. And I can understand that it is difficult in some settings to implement it in a consequent manner. But if we don't do this, we will have major problems in the future.
I agree. Thank you, Andreas. So, is there any other burning questions from the audience? If not, I will just pass the microphone to Gareth for any sort of Penta ID network news or things that he would like to share with us.
Oh, thank you very much. But I have nothing to add beyond saying a huge thank you. I thought that was a really interesting and informative session, and I hope that others will feel that they can email as well if you've got additional questions at the end of this. And if you're not already a member of our network, please do get in touch, and Matteo can provide the information of how to join. He's already put that into the chat. And this was a great ending to the year. I think it's really good that Adilia and Laura pulled this together at fairly short notice. I think it was a really good session, and we look forward to an energetic year ahead with more aperitivos. Thank you very much, everybody.
Thank you, everyone. Thank you, Gareth.
Thank you.
Well, have a good evening or rest of the day or morning, wherever you in the globe are. And lovely to have had Fabianne and Tanu. Thank you once again, and Andreas and Emmanuel and Adilia.
Thank you.
Thank you.
Bye-bye.
Bye. Thanks.